This is Nancy Steinfurth, former Executive Director of Liver Health Connection, which just recently merged with Vivant Health, and I'd like to welcome and introduce you to our next panel of speakers. Our first presenters are Carol Jimenez, JD, who is the Deputy Director for Strategic Initiatives, and Jessica Deeren, epidemiologist with the Office of Infectious Disease and HIV/AIDS Policy for U.S. Health and Human Services. Ms. Jimenez has spent her career working to improve the health of vulnerable populations as a practicing health attorney for almost 30 years. Additional experience includes works at the Centers for Medicare and Medicaid Services, implementing a section of the Affordable Care Act. She then moved to the HHS Office of Minority Health until she started at OIDP in January 2019. Ms. Jimenez leads the viral hepatitis work of OIDP in developing the first ever STI National Strategic Plan, the next iteration of the Viral Hepatitis Strategic Plan, and work on the HIV Strategic Plan and the Vaccine Plan. Ms. Deeren has been an epidemiologist in local, state, federal, and global levels of public health. She's worked on disease outbreaks in Orange County, Florida, and San Antonio, Texas. Ms. Deeren's role at HHS includes development of the Viral Hepatitis National Strategic Plan, and coordinating viral hepatitis activities across the federal government. Thank you for joining us.
Good afternoon, everyone. Thanks so much to Hep B United for inviting us to talk with you today about our Viral Hepatitis National Strategic Plan. I'm Carol Jimenez, as you already heard. Next slide. And I'm here with my colleague, Jessica Deeren, our expert viral hepatitis subject matter expert and epidemiologist. Next slide. So you'll see, for those of you who were at the AASLD session a couple of weeks ago, you'll see that the slide deck in many ways looks similar, but we have, although the look is the same, some of the information is different, that we are going to focus today on not just the Hepatitis National Strategic Plan, but how it focuses on hepatitis B issues. One of the things that we have come to understand as we talk to different stakeholders is that it's not clear to everyone all the different agencies that are part of the U.S. Department of Health and Human Services. So I just wanted to give you a snapshot to let you know that all are part of the same department. We all work together constantly. We collaborate, we leverage each other's programs and resources. So whether it's CDC, CMS, FDA, HRSA, SAMHSA, NIH, Indian Health Service, we're all one agency. We also do work with other federal departments, such as the Department of Veterans Affairs, Department of Defense, Department of Education, Housing and Urban Development, Department of Justice, and the Bureau of Prisons. But these are the HHS agencies that are under the same umbrella. Next slide. And then our office is a policy office, and our role is working with all of the different agencies in HHS and other departments as well, as I just shared, and leading development of policy issues, making sure that we collaborate on program and operational issues so that we try to minimize gaps and not duplicate efforts. We are small but mighty. Our subject matters range from viral hepatitis, HIV, STIs, the safety and availability of the nation's blood and tissue supply, and other issues as well. We've also been doing a lot of work on COVID-19, as I'm sure you can imagine. Next slide. So we're here today to talk primarily about the Viral Hepatitis National Strategic Plan. I am very pleased to report that we are on track to release it this month. It will be released in December. We are in the very final stages. A number of you, in fact, probably most of you on this meeting have already looked at the draft plan. Thank you so much to all of you who submitted comments, and thank you to those of you who signed on to the same set of comments, which made our lives analyzing them a lot more efficient. But everybody did get credit, whether you were the ones who put your letterhead on it or signed on to it. The credit was equal. And we received about 25 sets of comments, And we reviewed and analyzed every single one. We did things like sort them by topic area. And I think that you'll see reflected in the final plan the public comments that we received. We are very excited that for the first time, the United States has signed onto and committed itself to elimination goals. We have aligned with the World Health Organization elimination goals for this country. And as the NASEM report a few years ago indicated, they are doable, they are achievable in this country for hepatitis B and hepatitis C. You'll see in the priority populations some ways in which we have tweaked things based upon more recent data, and also an incredibly integrated approach with other public health concerns. So development of the plan has been led by a steering committee across 6 different federal departments and 13 HHS agencies. Next slide. So I already mentioned the integrated approach. My office is leading development of these 4 strategic plans, plus there is the 5th one underneath the 5-point strategy for the opioid crisis is an existing plan, but the 4 on top, we are leading development, and they will all be released within weeks. And in developing viral hepatitis, HIV, and STIs, the teams have really worked on a very coordinated basis to make sure that the vision, goals, priority populations, everything is aligned, and the strategies that we recommend really take a very integrated approach once again. We view all of these as part of the same syndemic, and that the syndemic also includes stigma, discrimination, and social determinants, and that we can't really achieve success on any of them unless we address all of them. Next slide. So here are the vision and the goals. I think you've seen these before. Can I have the next slide, please? Thank you. The thing that's newest is a goal that focuses specifically on surveillance and data. I'm sure that you share the same concern, but we in the federal government have been very concerned that we have a difficult time knowing where to focus our efforts geographically because of the lack of quality and completeness of the data. And I know CDC is expanding the number of states it's giving funds to, and we're looking to make sure that hepatitis surveillance and data are really strengthened through this strategic plan. Next slide. Excuse me. So the priority populations, in working with the current iteration of the Viral Hepatitis Action Plan, we felt like we had too many priority populations, and that if you have too many, none become priority. So what we tried to do in this one, or what we did, is divide them by the virus and by whether it's acute, chronic, or the mortality. And so we still end up with a fair number of priority populations, and these are populations that are based on nationwide data disproportionately impacted. But for those of you who work in one specific area or with one population, it will give you a much narrower focus to work with. And we do this, again, based upon nationwide data with a big focus and explanation throughout the plan document about how we use the data to determine this, to help guide you in using the data that pertains to your jurisdiction or the population you serve, so that you can figure out where to focus your efforts and resources to have the greatest impact. Next slide. And with that, I'm going to turn the presentation over to Jessica Deeren.
Thanks, Carol. The plan also has indicators that we will use to measure progress over the next 5 years. So we have 5-year and 10-year targets. The 10-year targets align with the WHO elimination goals, which WHO defines as a 90% reduction in incidence and 65% reduction in mortality from baseline to 2030. There are 4 hepatitis B related indicators: reducing acute hepatitis B infection, increasing birth dose vaccination rates, increasing proportion of people aware of their infection, and reducing hepatitis B related death rates. And all of these 2030 targets align with WHO's elimination goals. Next slide. For hepatitis B, we have 3 disparity indicators. So 3 of the core indicators have disparity indicators. And we know that in order to reach elimination goals, we need to appropriately address the disproportionately impacted population. The disparity indicators are reducing acute hepatitis B in people who inject drugs, increasing awareness among Asia Pacific Islanders, reducing mortality among Asian Pacific Islanders, and also among non-Hispanic Blacks. Next slide. Next, I'll go over the 5 goals and some key focus areas that pertain to hepatitis B within each goal. Goal 1 is to prevent new viral hepatitis infections. The first step is to increase awareness of viral hepatitis to improve awareness of infection, reduce stigma and discrimination. Through communities and people with lived experience, we can utilize community members to deliver culturally competent messages. We also want to increase uptake of hepatitis B vaccination. The hepatitis B birth dose uptake rate continues to increase each year, which is great, but we still have some work to do. We need to continue to address vaccine hesitancy and promote hospital quality measures. And as we all know, hepatitis B vaccination among adults is woefully low, so the strategic plan supports vaccination in a broad range of clinical and non-clinical settings to address missed opportunities and reach people where they are at. So settings can include HIV and STI clinics, refugee health clinics, correctional facilities, and locations that serve people who use drugs and people experiencing homelessness. We should also focus efforts to increase access to harm reduction services, substance use treatment, and peer navigation. Next slide. Goal 2 is to improve viral hepatitis-related health outcomes of people with viral hepatitis. Some key focus areas are to increase hepatitis B testing and linkage to care in clinical and non-clinical settings, leverage coverage for preventive services, and reduce price and insurance barriers for both vaccination and screening, expand capacity of public health and provider workforce to screen and treat, for example, by promoting collaborative integrated models of care. So, for example, encouraging hepatitis B testing and vaccination in substance use disorder clinics. We also encourage improving implementation and uptake of post-treatment care and monitoring, such as increased hepatocellular carcinoma screening, and also advance research to improve hepatitis B diagnostics, such as point of care or rapid tests in the United States, and therapeutics for hepatitis B cure, which NIH has already released their strategic plan last year on a pathway to reach a cure. Next slide. Goal 3 of the plan is reduce viral hepatitis-related disparities and health inequities. The strategies within this goal can be tailored to focus on the priority populations that we presented earlier. I think the Hep B United coalitions really have a key role in this goal. So this slide shows some of the overarching objectives and key strategies from the plan, which are reduce stigma and discrimination through engaging community leaders and enforcing protections that prohibit discriminatory practices, reduce disparities by fostering partnerships with organizations that serve disproportionately impacted populations, expand culturally competent and linguistically appropriate viral hepatitis services, and address social determinants of health. The plan encourages whole person systems of care that address co-occurring conditions such as viral hepatitis, HIV, STIs, and substance use disorders, and co-locating these services. Next slide. Goal 4 was added to this strategic plan to bring attention to the need for improved viral hepatitis surveillance and use of data. These are some of the high-level objectives. The goal 1 is to establish national capacity to conduct public health viral hepatitis surveillance through coordination of data reporting across healthcare facilities, laboratories, and public health departments. Improvements in public health surveillance can also be supported from the clinical side. So we can support surveillance by improving quality and completeness of clinical and laboratory data reporting, including risk factors, race, ethnicity, country of birth, and pregnancy status reported to public health departments. These data elements will also help provide data to identify the disproportionately impacted populations. So to improve the health exchange between public health and medical providers, we can use interoperable health information technology, develop standardized data collection strategies, and utilize standards-based data elements. This will help improve reporting and sharing clinical hepatitis data, which can take a lot of the burden off of public health staff. It is important to effectively utilize surveillance data to develop and implement quality improvement processes by regularly monitoring the hepatitis B continuum of care. And these cascades can help identify areas for improvement in testing, linkage to care and treatment. Additionally, it is important that we disseminate best practices for data collection, analysis, and use of data. And I think this is especially important in how we monitor the continuum of care. We have learned that this requires significant time and resources to gather the data, clean it, and report it out so it's useful to our partners. So how can we learn from programs that have already implemented this and utilize scarce resources effectively? Next slide. Goal 5 is achieve integrated, coordinated efforts that address the viral hepatitis epidemics among all partners and stakeholders. Objectives include integration of programs to address this endemic by leveraging resources from other programs, increasing collaboration across public and private stakeholders to coordinate strategic planning efforts and develop elimination plans, evaluate, scale up, and disseminate best practices in integrating programs. And finally, as part of HHS's efforts to implement the strategic plan, the next step for us is to develop an implementation plan for our federal partners. So we can't just write the strategic plan, we have to implement it next. So this plan will hold our partners accountable, identify areas for collaboration, and facilitate cross-disciplinary funding. We also encourage our non-federal stakeholders to continue to develop implementation plans on their own. And we will hold ourselves accountable through annual reporting as well. Next slide. So I want to highlight some examples of what our office and other HHS agencies are doing in hepatitis B. Our office has recently released a letter raising awareness that there are federal laws prohibiting discrimination on the basis of disability, including people with hepatitis B. So thanks to Hepatitis B Foundation for bringing this issue to our attention. The image on the right shows a letter that was recently posted on our website, encouraging health professional schools to review their policies and to follow CDC recommendations on healthcare professionals with hepatitis B. As mentioned previously, the NIH released their strategic plan last November on a pathway to cure hepatitis B. So that's really exciting. And our office has also been working with the Office for Minority Health and CDC on their hepatitis B demonstration project, which many of you are funded through. So we look forward to seeing best practice come out of this in the future. And Lucy Martin-Braswell, who leads this project, also has a poster presentation about the project if you're interested in learning more. We are also looking at ways to increase hepatitis B vaccination among adults, and the Vaccine National Strategic Plan also includes strategies to increase vaccination among adults. So it is a key issue for our office as well. Next slide. Finally, I want to end by saying this plan sets a roadmap for the nation to work towards elimination of viral hepatitis by 2030. However, it depends on all stakeholders, including your organizations, to implement these strategies. So we rely on you to provide evidence for what works and share them through publications, conferences such as this. And you can also promote your elimination work on our Mapping Hepatitis Elimination website. We need to add more hepatitis B elimination projects to this map. So if you're not already included, reach out to us to be added. Finally, we shared this last year, but we encourage our partners to continue to utilize the partner planning guide to develop elimination plans and take a look at the elimination plans that are on the map to see what other states, regions, or organizations are doing. There are some great examples on there. For example, we recently highlighted Hawaii's elimination plan, which was just released last year. Next slide. So thank you for allowing us to share the next viral hepatitis national strategic plan, and we look forward to answering any questions.
Thank you. Our third panelist is Carolyn Wester, MD and MPH, who has been the director of the Division of Viral Hepatitis at the Centers for Disease Control and Environment since January 2019, where she just released the division's ambitious 2025 strategic plan. Prior to this position, she was medical director of the Tennessee Department of Health's Division for HIV, STD, and viral hepatitis since 2008. In addition to her management experience, Dr. Wester has significant clinical and research experience, including principal investigator or co-investigator of several NIH-funded research studies in Botswana, as well as authored many articles and presentations on viral hepatitis and other topics. Welcome.
Good afternoon. On behalf of the Centers for Disease Control and the Division of Viral Hepatitis, I'd like to thank the organizers for this opportunity to provide an update on hepatitis B data and programs. Next, over the next few minutes, I'll provide an overview of CDC's Division of Viral Hepatitis, updates on proposed national hepatitis C vaccine and screening recommendations, a brief overview of new funding opportunity for health departments, some of the outcomes from the first year of an ongoing hepatitis B demonstration program, and also the division's ongoing efforts to increase hepatitis B awareness and education. Next. CDC's viral hepatitis program is supported through federal appropriations. Appropriations supporting our program over the last 8 years are listed here. Despite several small increases in fiscal years 16 and 18, appropriations for core viral hepatitis program activities remain modest at $39 million per year. Viral hepatitis program also works closely with a number of other partners, both within and outside of CDC and within and outside of federal government to advance viral hepatitis elimination goals. Some examples within the Centers for Disease Control include the National Center for Immunization and Respiratory Diseases, which supports vaccine recommendations and implementation, including the perinatal hepatitis B prevention program, vaccine for children, and also the 317 vaccine programs. We also partner with the National Center for Injury and Prevention Control to prevent infectious consequences in the context of high-risk drug use. Next slide. This provides a brief organizational review of the Division of Viral Hepatitis. Our division is housed within the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. We have approximately 100 full-time staff. We're small but a very prolific division. This org chart outlines some of the senior leadership positions within the division. The top 2 lines illustrate the Office of the Director, and the lower row indicates our 3 branches: Epi and Surveillance, Prevention, and Laboratory. Each branch is supported by several teams. Scientific activities and work supporting state and local health departments span all 3 branches. However, the work that informs the development of national viral hepatitis testing and vaccination recommendations is conducted primarily within the prevention branch under the leadership of Dr. Noel Nelson. Next. As I mentioned, CDC also works with a number of other federal partners, including SAMHSA, a Bureau of Primary Health Care, CMS, Indian Health Service, etc., and the Office of Infectious Disease and HIV/AIDS policy plays a coordinating role. As you will hear from my colleague Carol Jimenez next, the Office of Infectious Disease HIV/AIDS Policy recently led the development of the 2025 National Viral Hepatitis Strategic Plan in coordination with CDC and a wide range of other federal partners. While the plan itself includes goals, indicators, and strategies across all three major hepatitides in the U.S., the core hepatitis B indicators are listed on this slide and include indicators to reduce new infections, increase the rate of birth dose vaccination, increase the proportion of people aware of their infection, and to reduce the rate of hepatitis B related deaths. For each indicator, the measure, baseline data, data source, and 5 and 10-year targets are listed. Although not listed here, indicators have also been determined to reduce disparities related to hepatitis B, especially among disproportionately impacted groups such as racial ethnic groups and people who inject drugs. Next. Before moving to proposed hepatitis B vaccination and testing updates, I want to provide a brief overview of hepatitis B incidence and the remarkable successes that have been achieved over the past several decades. Next slide. This slide illustrates the estimated number of acute hepatitis B cases in the U.S. in the blue line from 1980 to 2018, coupled with several key vaccine recommendations throughout the years. Specifically in 1982, the introduction of vaccine recommendations for certain high-risk groups, 1984, to infants born to Hep B surface antigen positive women, 1991, universal infant vaccination recommendation, 1999, a catch-up vaccination for children and adolescents not previously vaccinated, in 2005, a universal birth dose recommendation, and in 2011, for adults less than 60 years of age with diabetes. Tremendous amount of progress has been made with respect to preventing new hepatitis B infections. The next two slides illustrate the vaccine uptake directly related to the 1991 and 2005 recommendations. Next. This slide summarizes pediatric hepatitis B vaccination coverage from 1994 to 2019. Remembering that universal infant vaccination was introduced in the U.S. in 1991, or 3 years before this slide begins, we can see through this figure that the full impact of that universal childhood vaccination recommendation wasn't realized until nearly 10 years later, or around 2000. However, once achieved, rates have remained stable at and above the Healthy People 2020 target of 90% for nearly 20 years. Next. The rates of hepatitis B birth dose coverage are illustrated in this slide. Coverage for the birth dose vaccination, which was recommended in the U.S. in 2005, is continuing to make progress, yet still falls below the Healthy People 2020 target of 85%. Parenthetically, these are rates of all children receiving birth dose vaccination, whereas the rates of birth dose vaccination among pregnant women, among children born to pregnant women known to be Hep B surface antigen positive are much higher, about 97%. Next. This slide illustrates the rates of reported cases of acute Hep B in the U.S. over the past 15 years, stratified by age group. You can see the successes achieved over the past 15 years in the U.S. as a result of the implementation of these two vaccination strategies, the pediatric and birth dose recommendations. Specifically, the teal line and arrows demonstrate that the rate of new infections among individuals in their 20s has dropped from 4.0 or higher in 2003 to less than 1.0 in 2018. Similarly, the maroon line or arrows at the very bottom indicate extremely low rate in this age group, the 0 to 19-year-olds, over the past decade. Conversely, we see a slower rate of decline among 30-year-olds, as well as increasing rates among susceptible adults in their 40s, 50s, and 60s, attributed primarily to injection drug use. Next. With this in mind, we move to adult hepatitis B vaccination considerations. Next. As the rates in the two slides prior indicate, we have a long way to go regarding vaccination coverage among adults. This slide demonstrates that in 2017, Approximately 26% of all U.S. adults were estimated to having been vaccinated via risk-based recommendations. Next. In 2018, the following year, ACIP, or the Advisory Committee on Immunization Practices, released an updated recommendation and report regarding the prevention of hepatitis B in the United States. This report recommended hepatitis B vaccination among adults at risk for infection by sexual exposure, percutaneous or mucosal exposure to blood, such as injection drug use, healthcare personnel, or persons with end-stage renal disease or diabetes, as well as other groups, which include travelers to regions with high rates of hepatitis B infection or persons with certain comorbidities, such as HIV or chronic liver disease. That same year, the same body recommended a recommendation for the use of a novel adjuvant 2-dose vaccination among adults. Next. Scientists within DVH are leading work to update the 2018 risk-based vaccination recommendations. Specifically, a recommendation for universal vaccination of adults born before 1991 is being considered. That process is still ongoing, but includes ongoing deliberations and evidence review conducted by the ACIP Hepatitis Work Group and an ongoing economic evaluation that is nearing completion. Presentation to the ACIP, or Advisory Committee on Immunization Practices, is planned in 2021. The timeline beyond that will depend on feedback and guidance provided by ACIP. Next. Well, what about hepatitis B screening and testing recommendations among adults? First, it's important to realize that while testing and vaccination are complementary, and our attempts are certainly made to harmonize the two, the recommendations are developed through separate processes and by completely separate groups. Vaccination recommendations are developed by ACIP with literature reviews and analyses regarding safety, efficacy, and cost effectiveness, and proposals are presented and considered and ultimately determined by that ACIP practices committee. This is different from screening and testing recommendations, which are developed by a number of different groups, including CDC, U.S. Preventative Services Task Force, as well as the American Association for the Study of Liver Disease, to name a few, which are based, depending on the organization, by systematic reviews of efficacy, utility, and cost effectiveness. And some groups also rely on the opinion of subject matter experts, especially in areas where scientific data is lacking. Next. As we consider the screening recommendations, we're reminded of the estimated prevalence of hepatitis B in the United States, groups that are disproportionately impacted, as well as the fact that only about a third of people living with hepatitis B infection in the United States report being aware of their infection, which is reflective of huge testing deficit among people living with active hepatitis B infection. Next. So what are the currently recommended hepatitis B testing recommendations in the U.S.? In 2008, the Centers for Disease Control provided formal hepatitis B testing recommendation for Hep B surface antigen among persons with identified risk. In 2017, CDC coupled with the American College of Physicians to develop hepatitis B vaccination screening and linkage to care best practices, which was based on a literature review from 2005 through 2017. It's important to recognize that while the 2017 best practice document provided updates, it is not considered a formal recommendation statement. Next. Hepatitis B screening recommendations by various groups are outlined in this slide. Risk categories are in the rows, and various recommending bodies' recommendations are listed in the columns. First, you can see that the U.S. Preventative Services Task Force, both in 2014 and also in their 2020 draft, has the most restrictive list of identified risks. Next, 2008 CDC formal testing recommendations expands those risk categories somewhat, and the 2017 American College of Physicians and CDC joint best practice document expands that further. Last column is the 2018 AASLD guidance, which contains the most risk groups and also relies more heavily on expert opinion than the other documents. The blue circle in the second column highlights the 3 risk groups: persons with a history of incarceration, with a history of hepatitis C, or with history of multiple sex partners or a history of an STI that were included in the best practice document in 2017, but still remain outside of the most recent formal recommendations issued by CDC in 2008. Next. This slide shows the evolution of and ongoing differences between the types of Hep B serologic testing recommended by the groups as well. So USPS Task Force recommends, as well as CDC 2008 guidelines, primarily focus on Hep B surface antigen screening, whereas the best practice document issued in 2017 expanded to 3-panel testing, and AASLD guidance in 2018 recommended 2-prong approach listed here. The advantage of including all 3 serologic tests, as long as it's covered by cost effectiveness data, is that it can pick up occult hepatitis B infection, which is particularly important among persons receiving hepatitis C treatment, and can distinguish between persons who remain susceptible to infection from those who are immune, either through vaccination or resolved infection, which could be particularly relevant in the context of a parallel universal adult vaccination recommendation. Next. Our division is currently working to propose updates to the 2008 hepatitis B testing guidelines, which include proposed one-time universal screening of adults born before 1991, adding the 3 additional risk groups. And this is important because even in the context of a universal vaccination recommendation, having risk groups with periodic testing is important to identify. And then also updating the serology recommendations to a 3-test panel. The analyses are being completed, including the cost-effective analyses, with the aim of publishing in 2022. Next. We now move to some examples of how the division is working with outside partners to implement viral hepatitis practice. First, mention the division's new integrated prevention and surveillance funding announcement for health departments. This announcement funding opportunity is open to state and local health departments who have the statutory authority to conduct disease surveillance. It has this iteration of the announcement was published at the end of August. Applications are due December 1st, and the award is anticipated to start in May 2021. It has 2 required components. Component 1, next slide please, for viral hepatitis outbreak response and surveillance. Component 2 for viral hepatitis prevention, including elimination planning. And then also an optional component, component 3, special projects to prevent, diagnose, and treat infectious consequences of drug use. Next. The Division of Viral Hepatitis is also working with the Office of Minority of Health to implement a hepatitis B demonstration grant program. Next slide. In response to hepatitis B elimination goals identified by the National Academies of Sciences, Engineering, and Medicine in 2018, the Office of Minority Health allocated $2.9 million in annual funding to support comprehensive hepatitis B prevention programs in collaboration with CDC and other key partners, including those listed here. Next. Initiative strategies are ambitious and span activities along the hepatitis B continuum, including prevention, testing, linkage to care, and policy levers, increasing implementation. Next slide. The 5 organizations listed here received funding in the first and second grant years and span a variety of activities, populations, and geographic locations. Next. The combined year 1 outcomes along the hepatitis B continuum of care are presented in this slide, with total outcomes depicted in yellow, as well as other outcomes stratified by certain patient populations in other colors. Overall, as reflected by the yellow bars, of the individuals with identified Hep B infection, 77% were linked to care, almost 70% were engaged in Hep B directed care, 30% were retained in care, and 19% were prescribed hepatitis B treatment, which seems low, but is consistent with estimates of persons with chronic Hep B infection for whom treatment is indicated. With respect to receiving treatment, some groups did better, for example, Asian immigrants, and others did worse, African immigrants, but this reflects only 1 year of data, several months of which were impacted by COVID-19. So additional follow-up and analyses is obviously being conducted. Other activities being implemented and analyzed through this initiative include analysis of vaccine series completion of 2-dose versus 3-dose, hepatitis B vaccine receipt among healthcare providers, and also the impact of COVID-19 on hepatitis B services, including testing, vaccination, and treatment, as well as utilization of telehealth. Next. The division continues efforts to increase hepatitis B awareness and education. Next. The No Hepatitis B campaign is a multilingual campaign that was developed by CDC and Hepatitis B United. It was launched in 2013 with 4 phases to date. The campaign aims to increase testing for chronic hepatitis B among Asian Americans. For 2021, the plan for the campaign is to go live during the spring. However, we will need to remain flexible due to COVID. We will be placing advertisements in Chinese, Vietnamese, and Korean, and will be using a mix of paid and earned media to optimize reach and frequency of the messages. In addition to the paid advertising materials, we'll continue to make materials available on our website to state and local health departments and non-governmental organizations. Next. Additionally, CDC has provided funding through a cooperative agreement to increase hepatitis B and C education, awareness, and testing. This agreement, known as VHNet, or Viral Hepatitis Networking, Education, and Training, has 2 parts. Part A, which is funded to Hepatitis B Foundation and the National Association of State and Territorial AIDS Directors, was meant to build capacity among hepatitis B and C coalitions to improve educational outreach and testing, and Part B, which is awarded to the University of Washington, to develop and offer free online hepatitis B and C training resource for healthcare providers. Next. Although there have been a number of accomplishments across hepatitis B and C, for the sake of this presentation, I'll highlight some of the hepatitis B related activities from this funding opportunity, which is now in year 4 of 4. These include the Hep B United Coalition, which is now reaching 30 partners in 20 states, 28 cities, and Washington, D.C. It's disseminated numerous newsletters and hosted multiple webinars to highlight best practices for hepatitis B awareness, testing, and linkage to care, and conducted over 72,000 hepatitis B education sessions and over 80,000 hepatitis B tests. They also, Hepatitis B Online was also launched in March of 2020. And as I mentioned, this cooperative agreement is currently in its final year. Next. We are delighted to be able to provide some follow-on funding opportunity through PS 21-2105, which has already been forecasted, has an anticipated announcement date of March 13th, 2021, and an anticipated due date of May 14th. Like its predecessor, 16-1608, this new funding opportunity will have 2 parts, and we expect to award 1 recipient under each part with an anticipated start date by the end of fiscal year 21. Next. In closing, I'd like to thank you again for this opportunity to share some of our programs, accomplishments, and proposals moving forward. And I'd also like to acknowledge my colleagues enlisted on this slide for their contributions to this presentation. Thank you.
Thank you. So we're now in the Q&A portion of our presentation, and I would like to begin by asking Carol Jimenez a question. Is there funding to support the activities and strategies of the HHS National Viral Hepatitis Action Plan? And if not, what's your plan to find the funding?
Thanks so much. I had meant to address funding in my remarks and appreciate it being the first question. Unfortunately, the plan does not come with funding for any of us federal partners or for any others in the nation. We do not have the ability to do that, but we have heard loud and clear from stakeholders around the country, whether it's health departments or advocates or researchers, that having the plan and laying such a clear roadmap and the elimination targets will help tremendously in others seeking funding and promoting funding. Our funding does come from Congress, and so it's really up to Congress to provide the department funding for viral hepatitis. I will also add that within the department, we have already worked on putting together initiatives, both what we can do with current funding and what we would do if there is additional funding. So we are ready to move forward.
Great, thank you. I would like to ask Carolyn to also answer that question for the CDC plan. Answer that question.
Great, thank you. So from the CDC viral hepatitis program perspective, and in the initial message within the plan, it highlights that the goals outlined in the plan are ambitious, and we need to continue to maximize existing resources and work across sectors, but that existing resources will enable us to move toward the goals, but achieving the goals nationally will be difficult without additional investments. But to get a little bit more specific, our 4 goals, reduce new infections, reduce viral hepatitis related morbidity and mortality, reduce viral hepatitis disparities, and establish surveillance capacity for viral hepatitis nationally. A number of those items are already well underway and can be conducted with current funding. So for example, just within CDC's viral hepatitis program, the development and promotion of national viral hepatitis testing and vaccination recommendations have been and continue to be underway, as you heard in the talk. Even with Hep B vaccination and testing recommendations, there are things moving forward right now, and certainly there are campaigns to promote that. Additionally, in our work with health departments, we just released a funding announcement. Again, it will bring us part of the way and provide the mechanism for further expansion should funds become available, but provides opportunities for elimination planning, promoting testing and linkage to care, and also establishing core surveillance and outbreak detection and response across jurisdictions. And I'll just finish up a little bit. The activities, the strategies, the goals that are outlined in both our plan and magnified in the national plan are supported well beyond the Division of Viral Hepatitis. So even within CDC, there are funds and activities within our center, Division of HIV/AIDS Prevention, and the Division of STD Prevention beyond our center, in the National Centers of Immunization and Respiratory Diseases, as well as Injury Prevention and Control, and certainly a number of other federal partners. HRSA's Ryan White program has put quite a bit of emphasis on elimination. Obviously, SAMHSA, our colleagues at, and Bureau of Primary Health Care, Indian Health Service, just to provide a few examples. So it's unlike HIV, which has a national treatment program, we don't have that. So we're having to work across a number of different sectors to reach populations that are covered or not covered through a variety of mechanisms. So it really takes integration. Thank you, I'll end there.
And I would just add to the list that Carolyn provided, other examples. NIH has a whole research portfolio. FDA works on issues related to this. The VA has a really great program. We all work together. We all try to coordinate efforts to leverage the resources that we do have.
All right, so I'm looking at a couple of questions for Dr. Wester, but I'd like to make sure that we balance. So I'm going to propose a question for Carol. How will the change in administration impact HHS and CDC priorities related to hepatitis B?
So that remains to be seen. We have not had the change in administration yet. I know that the Biden-Harris administration is making healthcare one of its priorities. And we expect there to be continued and strong interest in eliminating a variety of the infections that are currently public health threats, including hepatitis, but we'll see once they are actually in place.
All right, great, thank you. So I'm going to ask possibly a multi-part question for Dr. Wester. So let's see, CDC DVH is working with Quest and LabCorp to analyze U.S. hepatitis B blood panel data. Can you tell us anything about that, what you hope to learn from it, and if and when the results will be made public?
Well, I can tell you, I can't give you a specific time frame right off the cuff. However, I can tell you that there is, even as we work to build that surveillance capacity within the individual jurisdictions across the nation, there is tremendous opportunity to use large laboratory and administrative claims databases to provide glimpses, even at the jurisdictional level, of testing rates, and also to build jurisdictional cascades of care based on laboratory data. It's a little easier, or a lot easier, for hepatitis C, but it is also conceivable for hepatitis B as well. So I can't provide additional information right now on that, but I can tell you that in the absence of a national surveillance database, those provide valuable opportunities, and we've got teams looking into it right now.
Carol, I am wondering if there's an acceptable federal way to incentivize doctors to test at-risk populations for hepatitis B.
So, this is one thing that we think about a lot and have tried to pursue, but really I think the best way is to have quality measures for these things, and things like pay for performance, how they do on the quality measures to impact them. So we do work on that with CMS, but it needs to get up higher on the priority list. And I would just look to Carolyn as well to see if she has anything else to add.
I totally agree that quality measures play a role in that as well. And I also think that any kind of mechanisms, policies that can make it easy and automatic. So for example, electronic health prompts, or just integration into routine testing, whether that's into an antenatal panel or working with an electronic health record, or certainly at the lab level, while we're still looking in most cases at a two-step diagnosis for C and also a full panel for B, to make sure that the right tests are part of that panel as well.
So, not wanting to pick on you, Dr. Wester, but I have another question for you. This is related to your graphs. So this is a test, memory test. It says, since the HBV prevalence graphs and data are flat, does this show a failure of risk-based testing?
So getting back to the fact that of among adults that we only have 26% that are showing immunity, and we're showing increasing rates among our 30, 40, 50-year-olds, which is paralleling the increases that we're seeing also in reproductive age adults among hepatitis C acute infections, and also where we're seeing correlating at least temporally with the opioid epidemic. I think that what it has shown is a failure to implement fully these risk-based recommendations. And that's why we're looking very carefully at making a recommendation for a universal test recommendation among adults. Clearly, cost effectiveness will be a part of that evaluation. And in any kind of testing recommendation, so for example, with the expansion of the hepatitis C testing recommendation, which was at least released by CDC as well as USPS task force earlier this year,
you have to look at real world implementation versus what the recommendation states. So if they were implemented perfectly, I don't think we'd be looking for a universal vaccination recommendation, but vaccination recommendation. But since it hasn't been, clearly there's a need, and we'll look at the cost effectiveness. And if that drives it, then we'll move it towards it. It will reduce stigma, lost opportunities, and hopefully achieve what we're looking for, which is higher vaccination coverage.
The next question is for Carol. As mentioned in previous summits, many people affected by hepatitis B are ineligible for Medicaid. What are federal policy actions that HHS is doing to address this?
So a couple of things regarding that question. One, we are about to change administrations. So we need to see what the new administration brings into CMS and the Centers for Medicaid and CHIP Services. And a lot of eligibility is also federal law, which is enacted by Congress. So things that we've been working on with CMS so far, we may continue working on. We may be working on different things depending on what the Biden-Harris administration brings to the table. I know that's not very satisfying, but we are in flux.
So I'm scrolling through on my phone, and I'm wondering if there are more questions. I do see more related to USPSTF surveillance, and I believe we've addressed those questions. So let me quickly scroll through. Okay, that is the majority of the questions, so I'm going to throw another one in the mix. This is for both Carol and Carolyn. We're not on track to achieve the 2020 target for HBV-related deaths among AAPI. What recommendations do you have for community organizations to help lower this number?
So I'm actually going to kick it over to Jessica. Jessica, do you want to respond?
Yeah, sure. So actually with the 2018 surveillance data that's come out, we are moving in the right direction to reach the 2020 target. But of course, there's more that we can do to improve it. So we can increase awareness and testing among AAPI to increase diagnose or improve earlier diagnoses. We can utilize data to look at the continuum's care to improve linkage to care. So there, and of course, focus on the cure that NIH has already put a plan together for. And I'll pass it over to Carolyn if she wants to add anything else.
I think that we're going to have a lot of opportunities to learn, for example, best practices and from like the Office of Minority Health Initiative, but certainly there are some opportunities not only for continuing to promote the No More Hepatitis B campaign, but also to work to leverage the National Perinatal Hep B Prevention Program and make sure that focus is not only on prevention of mother-to-child transmission, but it's linked to community services so that infected pregnant women can get linked to care and treatment. And then family members tested and vaccinated. Mm-hmm.
Thank you. Final question, I believe. Are there efforts to build upon COVID vaccination strategies and infrastructure to promote and support increased adult hepatitis B vaccination?
So the department as a whole is working on initiatives to increase vaccination rates. We're concerned that vaccination rates have decreased because of COVID. And so building into all of the things we're doing catch up for kids, but we're also building in for adults as they get screened for other things. And we're still working on the distribution plans, although that will be state-based, but we're still working on that for COVID. Carolyn?
I'll leave it there. Thank you.
All right. I think that I've run us over our time, so I apologize to the next presenter. I want to acknowledge all of your presentations and thank you very much. Carol, you said earlier that we are a small, that you mentioned small and mighty, and this definitely describes this community. So we are a small and mighty team, and we appreciate everything that you do to help us in our efforts. So thank you.
Thank you very much.
Right. I would say on behalf of all of us, thank you. Thank you to all the folks who organize the conference and for all the work you do day in and day out. You're making a huge difference in our ability to do the work we do as well.
Great. Thank you so much, Nancy, Dr. Wester, Carol, and Jessica. It was really great to hear updates from our federal partners. And back at you, Carol. You definitely support the work that we do, and we really appreciate everything that you are doing at the national level. And now I'd like to introduce a quick word from one of our sponsors from the Plasma Services Group.
Have you ever wondered what good can come from your diagnosis? The medical industry relies on donors with recent diagnosis or autoimmune conditions who are willing to donate plasma. Some autoimmune conditions are so rare, we recruit our donors nationwide. The first step in qualifying to become a paid plasma donor is to complete our online donor form at psgdonors.com. Our team will contact you and provide detailed information on the qualification process. If qualified into our donor program, you will be compensated with a minimum of $200 per donation. As an FDA-registered facility, your safety is our #1 priority. Unlike regular blood donation, plasma collection is a little different. During this process, the liquid part of the blood, known as plasma, is separated from the red blood cells using an automated machine. Once the separation process is complete, the red blood cells are returned to the donor and your plasma begins to regenerate within 24 hours. The donated plasma is then used to make test kits for diagnosis. Medical research, product development, and manufacturers rely on antibody-rich plasma to diagnose diseases, and further research and development for new and better test kits. So why should you donate? Because $200 per plasma donation helps offset medical costs, and you can take pride in the fact that your participation profoundly affects the health and well-being of millions all over the world. And most importantly, your identity is kept strictly confidential. We value you as a vital link in the diagnostic process. You can make a difference, one donation at a time, by changing the future with research today.
Hi, everyone. My name is Catherine Freeland, and I'd like to warmly welcome you to today's session, Hepatitis B Education and Outreach during COVID-19. As you all know, many of our community-based testing services and general healthcare services have been put on pause or on hold, or have faced significant challenges during the past 10 months. We know that hepatitis B testing and vaccination is down significantly, and our community-based testing initiatives have been forced to come up with innovative strategies and solutions to still meet the needs of our communities. For example, in Philadelphia, we've initiated what we're calling a contactless testing hepatitis B initiative, where we've conducted Zoom education in multiple languages and provided free testing vouchers linking people directly to labs for free testing. COVID has forced us to be creative, and today we'll hear more details on programs from around the country that are diligently working to meet the needs of some of our most vulnerable communities. The format of today's session will be a panel of 5 speakers highlighting their outreach strategies during this challenging time. We'll follow their presentation with a discussion section, so be sure to type in any comments or questions or strategies that you've used throughout the time. Our first speaker today is Jane Pan, who many of you know as the Executive Director for HBIDC. She's engaged key community leaders to work with health clinics, pro bono physicians, university researchers, and advocates to promote the understanding of hepatitis B, C, and HIV through public-private partnerships. Through her leadership, HBIDC has provided education to over 32,500 individuals, screened over 18,000, and identified over 5,000 individuals vulnerable to infection in need of hepatitis B vaccination in the DC area. Thus, she won the recognition with HBIDC of the U.S. Department of Health and Human Services for their work in screening patients for viral hepatitis. I'd like to now welcome Jane Pan.
Good afternoon. My name is Jane Pan, and I'm with Hepatitis B Initiative of Washington, D.C., HBIDC. We are a community-based organization. Our vision is a world free from liver diseases caused by viral hepatitis. Our mission is to mobilize communities to prevent liver diseases caused by viral hepatitis. And through collaborative partnership, we outreach and educate the at-risk, underserved, and hard-to-reach communities. We provide free viral hepatitis screenings, refer to clinics for HBV vaccinations and linkage to care, and follow up for retention in care. Next slide, please. So we network with CBOs and FBOs with the trusted leaders of the ethnic communities of Asian, Africans, and Hispanic immigrants. We work with primary care doctors' clinics who sees a lot of hepatitis B patients, partner with hospitals and universities for linkage to care, or collaborate on projects. And we also work with medical associations, local Department of Health of DC, Maryland, and Virginia, and Fairfax County, and federal and state offices of the Office of Minority Health, DC Mayor's Office, and Maryland Governor's Office. Next slide, please. Since March, we have not been able to provide in-person outreach and in-person screening or vaccinations. To conduct outreach in a safe manner and in compliance with CDC guidelines, we modify our outreach safety protocol for in-person outreach and distribution of HBV education materials and COVID-19 materials in combination with our PPE distribution. Our PPE includes one-pagers about viral hepatitis, prevention, risk, transmission method, free screening information, CDC COVID-19 materials, hand sanitizers, and cloth and reusable face masks. By doing so, we build new trusted relationship for future providing free screenings. Next slide, please. So HBIDC has sustained its work throughout the COVID-19 pandemic and keep our employees working remotely from home and also complying with CDC and local orders. In-person outreach and screening events has been canceled since March, like I said before, and however, we follow up with previously tested HBV positive individuals and on retention of care and unemployment and other resources. We raise awareness by hosting COVID-19 webinars and viral hepatitis health literacy and where to get tested for COVID-19 in their local jurisdictions, or where to get tested for free viral hepatitis screening with us. We apply and receive some HOPE grant to distribute PPE along with viral hepatitis education materials, which help to rebuild trust in the community. All of these, we have to move fast and think quick to integrate new ways to serve our community in a safe manner and develop and train our staff the safety protocol and procedures for outreach, education, screening, and vaccination, and more focused efforts on evaluation and trainings. Next slide, please. Our outreach effort also using social media. We increased our social media presence by supporting and sharing partners' material on social media from the District of Columbia, Maryland, and Virginia. We post and share and raise awareness on subjects such as hepatitis testing days, World Hepatitis Day, October as National Liver Cancer Awareness Month, and also raise awareness of hepatitis B and hepatitis C, where to get free testing, and then also post a lot on CDC no hepatitis material, and also promote Hep B coalition partners, and also the baby vaccination with the Hep B vaccine, and mental health, COVID-19 preventions. So we post on social media about 3 to 5 times weekly on Facebook, Twitter, Instagram, YouTube, and LinkedIn. And then we also joined the ethnic group where HBIDC staff or partnering leaders are group members such as Burmese, Chinese, Amharic, Korean, Mongolian, and Vietnamese. Next slide, please. So we have continued HBV education and outreach in the District of Columbia and using virtual learning webinars on viral hepatitis and COVID-19. We have translated into different languages, and we have developed a one-pager to distribute on with our PPE packages, and then also we distributed 1,500 PPE kits to coffee shops and storekeepers, their employees, construction workers, parking attendees, homeless people, to churches, Ethiopian churches, Chinatown, DC Chinatown, and Hispanic neighborhoods. And the Embassy of Mongolians for the stranded citizens due to Mongolia closed their border to the border closure. Next slide, please. So to continue our services, we developed 3 different plans. And the first plan is we partner with clinics who sees a lot of hepatitis patients and see patients with high hepatitis in the community with high hepatitis prevalent rates. And 2, we developed an online hybrid screening model via telehealth. We have successfully screened over 60 individuals using our hybrid screening models from June to October. From July to October. We are circulating flyers promoting our hybrid screening on social media. The clients fill out the online registration form on our website. We make online appointments with the client at their nearest locations, LabCorp locations, and we provide the results via telehealth. In October, we started providing in-person health screening. We updated our safety protocols and procedures and trained staff on how to operate during COVID-19. It's by appointment only. Person fill out the registration form online. We provide them with the time for the appointment on the day of the visit, and when on the day, the person will wait in the car and call us upon arrival. We will go through the COVID-19 risk assessment, and if the person answers no to any of those questions, then they can enter the facility. And before they enter, we will take their temperature and also provide a mask, a reusable mask, over their cloth mask. And then also we provide them with a face shield. In October, we have conducted two successful in-person screening events, one in DC and one in Maryland, with a total of 87 participants. Here are some of the documents of the floor plan photos of our recent in-person event. The floor plan, we have to, before we have the in-person, we develop a floor plan to see where, how we keep the social distance, where we put our shield guard, and where people enter and where people exit. Next slide, please. So during this pandemic, providing the hepatitis B vaccination was the hardest thing to do. We couldn't do it virtually. It has to be in person. So when the doctor's office clinic, when they opened up end of June and starting in July, they were able to help us provide some Hep B vaccinations to their patients. But in October, we held one vaccination event. And throughout July and September, we were able to provide 135 vaccinations. The health screening. So this is the list of a health screening test that we do, that we provide. I won't go over this, and if you need the copy, please contact me. Okay. Linkage to care. So HBIDC worked hard in making follow-up calls. When we first started in March, when we had to close down right away, and so we started right away. We started making calls to Hep B, those tested Hep B positive with us from 2019, 2018, 2017, and 2016, to make sure these patients were receiving continuum of care by their healthcare professionals and were receiving treatment if needed. We assisted some to make appointments for telemedicine with their doctors and also help with the medication refills. And we connect many who either never made their initial appointments because they were too busy working, and also for those who lost their insurance in the meantime. By reaching out to these tested positive individuals, HBIDC staff was able to re-engage individuals who were not concerned or had fallen out of care, and then also for those who've been taking care, we was able to improve in their retention of care. And we refer a lot of the people for other social services like unemployment. We help a lot of people with unemployment and housing and food assistance and health insurance. Next slide, please. So this is the Hep B data comparison with 2019 before COVID, and also January to October of 2020. And with the three screening plans, we were, this year during the pandemic, we were able to screen 1,550 and found 48 positive, and 45 of those we were able to link to care. Next slide, please. So successes. These are our successes that by partnering with 6 clinics, and we were able to successfully screen the 1,500 people, and we linked 93.7% to care. We were able to conduct outreach and in-person screening safely by developing and continuously improve, train, and refocus our staff with the new service format and platform to achieve continuation of HBV on a virtual basis. Next slide, please. Oh, can we go back to that success slide? I just want to mention that picture. So this is the picture of our screening that with a partner with the AACF in Frederick, and also with Maryland Department of Health, and also Office of Minority Health, and that's the time when we screened 78 people. Okay, next slide, please. So challenges is when the pandemic first happened, our community partners were heavily impacted and had to force to cancel the in-person screening, and then also it had impacted our in-person outreach and screening events. And so we had to create right away to add an extra layer to our model to provide online screening, and also partner with other clinics that's open and create a safety protocol and procedure for person screening. Sustainability, we keep our staff working. We see a lot of our staff. We try to keep all our staff working, in which we were able to do because we had found the HOPE grant funding to distribute PPE and to the community. And then, but we have a shortage of staff because we have children doing online schooling at home, and then also taking care of elderly whose their senior daycare centers closed, or they come back from their senior living quarters. And then, although our staff are taking every precaution when distributing PPE, however, there are still risks. And so, we also very careful about that. So and then because of the recent COVID-19 surge, we might have to close down again. We won't be able to do the in-person, and then also the doctor's clinic is going to be closed. And so we might have to lock down for a few months, but we'll see. Next slide, please. So I would like to express our gratitude and appreciation to Hep B United and for organizing this summit, and also to our partners for your dedication to elimination of hepatitis. Please feel free to contact me if you have any questions. Thank you very much.
Thank you so much, Jane. Our next speaker is Yun Hua. She's the program manager at the Vietnamese American Cancer Foundation, where she oversees the daily implementation of the program's outreach and education activities. These activities include patient navigation, screening, hepatitis care, and cancer coordination. The programs provide linguistically and culturally appropriate health, communication, promotion, and continuum of care services, focusing on primarily Vietnamese-speaking immigrant communities in Orange County, California. She previously served as a professional staff in her dental school in Vietnam, where she provided the coordination of academic affairs, dental research, and community outreach and education. Her work experience helped to develop strong interpersonal and communication skills. Welcome, Yun.
Hello, everyone. First of all, thank you so much for Hep B United to invite me to be here today to represent the Vietnamese American Cancer Foundation to talk a little bit about the hepatitis B outreach strategy during the COVID-19 pandemic. At first, let me share a little bit about our organization. The Vietnamese American Cancer Foundation is a nonprofit organization was founded in 1998 by a group of cancer survivors and local physician and community members just to address the cancer issue in the community. Our mission is to prevent cancer, improve patient quality of life, and save lives through cancer education, research, advocacy, and services. Our programming focus on viral hepatitis B and C would lead to liver cancer if untreated, and breast cancer as the two foremost community health issue. About the community that we serve here in Orange County, we have the largest Vietnamese community outside of Vietnam with a population of about 200,000. But that based on the census in 2010. Right now, it's estimated that that population grew to about 300,000. And that is still believed to be undercounted. And the community we serve, as you could see on what I shared here, 69% of them are foreign born with, very limited English proficiency. And especially the seniors, 90% of them are limited English proficiency. And with that is also, they have a very low educational attainment compared to the total population in the county, with lower rate of high school graduate and lower rate of the population who get graduated from colleges with a bachelor degree or higher. And unfortunately, in this community, cancer is still the top cause of mortality. And that is a health disparity issue. For other community, is heart disease, but for the Vietnamese community, it's still the liver, it's still the cancer, and especially liver cancer. As you could see here for the total population, compared to the total population, liver cancer is the second top cause of mortality by cancer in the Vietnamese community. And is also the second of the top incident by cancer in this community, which is, we believe, is due to a very high rate of hepatitis B in the community, with about 8 to 13% of the population have the disease. And a lot of people in the population, they carry the disease, but they don't know, they are not aware of that, and unknowingly transmit it to other people. So one of the main program at VACF is the viral hepatitis and liver cancer program. The program has been there for more than 15 years, and we have that experience in provide the community level of hepatitis B and C services. It includes outreach and education, and from that we navigate the patient into the services that they need, link them to the health system and get the care, get the understanding, and also provide the screening. And from the screening, we identify individual and provide the care coordination for those who need the diagnostic, or for those who need help with vaccination. And for today, I would like to focus a little bit on the outreach and education aspect. Before COVID-19, we conducted outreach and education in a traditional way, which is we just go in where the community members live, work, prayer, social lives, such as community event, health fairs. We also have a weekly educational radio show and a TV show, and we organize community seminar and workshop. We also have that monthly meeting, which is we meet every last Friday of the month just to provide education related to health and also community resources, and try to keep the community updated with the health knowledge. Especially, we have some of the specialists and also the community champions talking about hepatitis and share about their experience in treating and in identifying themselves as a hepatitis B patient, and help to spread the word about the disease, just to raise that awareness and make people more concerned about their own health and also the health of their loved one. At the beginning of this year, about March, as all of us know, COVID-19 just hit us. And it was a big challenge, especially in the outreach and education, because the question is that how do we engage the community when we cannot go out in the community and cannot meet face to face? We work in the community for years, and we know that, when we don't have a choice and we have to go virtual or we have to go online, it's a big challenge, because this community, they are facing what we call the digital divide, which is here I put it into 3 different pieces: is the economic divide, usability divide, and empowerment divide. Economic divide is very straightforward. Some of the people, they just cannot afford the device or the internet access. And even if they have that access, the usability device, technology is complicated, that many people just couldn't use the computer or the smartphone. Even if you just give them one for free, That's the issue of the low literacy, and especially for the senior citizen, who are our main focus, who are the population that we really want to reach out to. And the last one, and also the most important, at least to me personally, is the empowerment device. Because even, they have the computer, they have the smartphone, they have internet access, everything is easy out there. But not everyone would make use of the opportunity that they have. They lack the initiative, they lack the skill to do it on their own. Imagine I believe that any of us will have a senior at home. Sometimes you just give them a device as a present, and then you just leave them there. They're not going to use it to the capacity of what it is to open to a new world for them. They rely on someone else. They rely on the mercy of other people's decision to guide them, to teach them how to do that. And most of the time, younger family member, they typically are not that patient to provide that empowerment to the seniors. It's just the matter of, apply. It's busy and they just leave it there. And that's are the main challenges when we have to go virtual, we have to go online to do the outreach. So we put together our thought as a team here at VACF. I would like to share the story of our team since March. It's not much, it's just some of a very simple strategy. We think, and how could we do this? Let's make it simple. Let's just start small. We want to reach out to people, but now everyone is at their own place. They there. We at our own place. We cannot meet. We cannot go out there. So how to find them? Who they are? We decided, okay, we don't know how to answer that question right now. Back then in March, why don't we just ask them? We asked some of the people out there in the community that we know to see how we could find other people just like them. So we started as a very small, that we do some of the Facebook posts. We also, make some call to the people that we serve. And it just happened as it's very simple, just a check-in during the COVID-19. How you doing? Is there something that, you need? Is there the fear? Is that something that you see that VACF could just help you? We started with identify their need and try to understand their need. And we started with some of the cancer patients and hepatitis B patients, those who need, the frequent visit to doctors. And from that, we get a lot of the feedback from the people that we serve, that they need the help with some of the basic necessities, some of the food and like BBE and things like that. Well, okay, so that's right now is the need in the community. As a community-based organization, we need to be responsive to their need. We want to talk about hepatitis, but they're not going to listen to us if they just think about whatever that is the most concerning issue with them right now. So we started to seek out for some of the donation and the support, and we start to distribute what we call the emergency care packages. From the check-in call, we distribute some very, very few emergency care packages, and we tie in there the information of hepatitis. And we use coronavirus as a way just to say, this is a virus that is right now is new. There's not a cure, like we don't know about it. But let's talk about hepatitis B. It's also a virus, and it's very we know about it. It's preventable, and there are ways to control it, even if you use it. So why don't you want to learn more about it? And we get their attention. And from that small group of people that we currently serve, we see that the words expand to other people around them. They tell their friend, they tell their circle of around them, their neighbor, their family. They let other people know about what VACF do. And from that, we learn about their need, and we learn about what they doing during the pandemic. Okay, they cannot go out, so they have to figure out a way just to keep that socialization. So where they are, and we learn that from the community we serve. They go online too. So it depends on the community that we serve, that you serve. You just need to know where to find them. For the Vietnamese community here in Orange County, Facebook is a very popular social media platform. If you talk about Instagram, if you talk about Twitter, you don't see a lot of Vietnamese people in there. But most of them, and especially for those who have a lower level of education, who have a lower income, that's a more popular platform that they use. So we invest more time in that, just to design the post, design the content, to post it in there, to promote about the activity and promote about the information that we would like to give it there. Could you imagine that in April, since April, we until now, we started with a very small group of cancer patients, survivor, hepatitis B patients that come to us for that kind of assistance. Right now, every month we have like 300-400 families, household family come to us. It's just to get the help and also just to learn more about the information. We organize the workshop, the virtual workshop, and also organize the drive-through educational event, which is they drive, they park in the parking, and then they just listen to the information that we share. At first, for those events, were very small. We only have like 7 to 8, sometimes 10 participants, especially for the webinar. But right now, every time when we hold a webinar, our attendance is go up to 60 or 80 every time. Because what we learn is that we need to keep it simple. When we promote our event and we saying that webinar or teleconference about hepatitis, about health, about liver health, we don't get people. So we step back a little bit. We think, okay, webinar, teleconference, is it just because we just say in those words is maybe just a big words to them, that they was just like, what is it? It's a webinar. What is it? It's teleconference. So how about just step back a little bit, use something that's more familiar to them. Use something that they use it daily. So we use the term that is more related to them. We don't promote it at webinar. We don't promote it at teleconference. We are saying, okay, we have a doctor who talk about hepatitis B, and you could just listen. It's just like a video call. Video call is something that is simple to you. It's just like you do FaceTime with your family member, or you just do a video call via Viber to your family member. So let's do a video call together. And people get it. Okay, video call. They call into us and they said, I want to do that video call that you talk about. could you just show me how? And, we trained them to use Zoom. We trained them to use a new tool. It's just a matter of spending that time, try to get their attention, try to catch that, come to us. That is something that you could do. It's simple. It's not that hard. As long as that you are willing to try, we are here. We trying with you. And our staff spent time on the phone, talk to them, talk to the seniors, talk to those, they don't have a clue of any English word, but they could use Zoom to attend our webinar. And from that, it empower them. It was just like they cannot believe that at this age, they could learn something that new. They could do these things. And from that, it just opened a big door to other things to them. Because as they know how to use those platforms, they could attend like virtual church, like they attend other virtual, classes, group activity. And we just got the feedback like, during the pandemic, we just really need somebody to spend that time with us, to talk with us, to have that space. And you just there, listen to us, spend time and try to empower, to do new things, to make us learn about these, learn about things that we have never thought that we could learn. And some even share that it just stay with me. They just shared, even within my family, my kids, my grandkids, they are not that patient like you. When I ask them to show me, how to use this app, how to use that app, they just kind of telling me that they don't have time. They just do their things. But you guys here at VACF, you guys spend time with me. You guys trying with me, and you guys make me think that I could do it. And you guys prove to me that I could do it. And I'm just thankful for that. And from that, the word just spread to other people. And that's how that, from April until now, we have been outreach to more than 3,000 family and household. We pass out a lot of flyer and fact sheet about hepatitis B every time when they swing by the office. And we got more than 1,200 new clients just within April to this point. And I'm just so proud of the team that we have right here as a nonprofit. They just work, and they see the client that they serve as somebody relate to their family member, and that's the focus on that human connection, and try to empower the community about their own health. That's VACF story from March until here that I would like to share. So just a brief summary of that. It just, try to start something just small. Don't be ambitious, and try to understand who are the people that you want to find. What are their needs? Because you just cannot go out and tell them about what you want to tell them without knowing their need, and find where they are, what they use. Keep things simple, keep things familiar to them, as simple as possible, and focus on that human connection and empower them to be in charge of their own health. And is a non-traditional setting is, it forcing us to do something new, but it's actually, I think it's just something that very in general, that's how you connect with people. Some of the other way that we have learned is that, the radio show, the TV show are also very helpful, and the connecting with where the other organization in the community, that they didn't know that VACF trained people to do Zoom. And then it's just amazing that, they heard from client that we train people to do Zoom to attend the health webinar at VACF. And they help to spread that word to other people in the community. It's just because sometimes it just seems that they need that training. They need to know how to use that new technology, so they could go to churches online and things like that. And it just, that's just a brief summary of what we've been through since April. And so that's the lesson that we learn from how we do the outreach. And it's just very interesting, or at least to me. We have never thought that we will do this kind of, like food or emergency care packages distribution. And it's just with that flexibility with the patient, and being creative in the way that you reach out to people, with the empathy of their situation. You could engage people in the work that you do and raise that health awareness. And the last thing that I really want to emphasize is that the coronavirus is challenging and make us, change our life completely. But it's a really good opportunity to tie it to the work that we do to talk about virus. Because back then, when you talk about hepatitis B virus, it's a silent killer. It's so silent. People just don't care of it because they don't see the impact right away. But right now, the coronavirus is on the news everywhere. So there's no cure yet, no vaccine yet. Everything is in process. It's a really good opportunity to use that to tie it to the hepatitis and to educate the community and just talk about it like, virus together. We could do this. Let's do it together. And that's how we changed our outreach from a traditional way into more of virtually and more to reach out to people in a very, very creative way. Here you could see that it's a pictures of VACF team and also the volunteer at one of the food distribution event that we have here. And at each of the event like that, we also offer like the hepatitis B screening on the spot for the patient if they want. It is a drive-through distribution. There's no contact. And if they want the free screening, we provide them a packages. They just complete the paperwork and go to the lab on their own, and they will receive result later. And that's how we tie our health services into the immediate need of people. And that is how you could engage them. Just need to understand that what do they need, and what is it that they will make them care about what you talk about. If you want them to care about what you talk about, you have to care about what they want first. So it's a two-way of communication. And my presentation is just very simple and very short today. Please let me know if you have any question. I would be more than happy to address that. And thank you so much.
Thank you so much, Yoon. Your presentation serves as an important reminder to keep the community's needs at the forefront of our mission and to keep things simple. Our next panelist is Dr. Yuen-Li Nguyen. She's the director of the Hepatitis B program at the Charles B. Wong Community Health Center. She is involved in providing and updating hepatitis B protocols internally for OB and internal medicine departments, training internal medicine providers to care for hepatitis B patients, and advocating for viral hepatitis initiatives at city and state government levels. She has been practicing as an internist for more than 10 years, providing primary care to underserved populations. She is committed to caring for the immigrant population and has a special interest in hepatitis B. She is a graduate of the Sophie Davis School of Biomedical Education and NYU Medical School, and she completed her primary care residency at NYU Langone Medical Center. Welcome, Dr. Nguyen.
Hello, everyone. My name is Yuen Nguyen. I'm the Hepatitis B Program Director at Charles B. Wang Community Health Center in New York City, and I will be presenting about hepatitis B outreach strategies during the COVID pandemic. I will also touch a little bit on patient care during this period of time. Before I go further into my presentations, I would like to thank our sponsors, the Office of the Minority Health, Robin Hood Foundation, and the New York City Council for making it possible for us to have a hepatitis B program and to do outreach for hepatitis B. And I would like to thank our team also, who work very hard for the hepatitis B program and who have contributed greatly to this presentation. So a little bit of background about our health center. We are a nonprofit federally qualified health center in New York City. We primarily serve the low-income Asian immigrant community, and we provide internal medicine services. Also, we provide pediatric, OBGYN, mental health, social work, and dental services for our patients. We have hepatitis B programs, and this program, we provide linkage to care and care management for high-risk chronic Hep B patients. And we provide free Hep B screenings, and also we have a Hep B mom program, which we do care management for pregnant women to prevent perinatal Hep B transmissions. So as we all know, COVID-19 pandemic hit New York around mid-March and early April, pretty much hit around the world. And at that time, there was executive order in mid-March to have New York residents shelter in place. So there was a lot of restrictions during that time. And during the summer month, the restrictions loosened up a bit because the infection rate was getting lower. However, in the next few months, we expect that it will change as the cases increase in New York. And right now in New York City, the positivity rate is about 3%. So how did it impact our clinic and our patient care? A lot. As we all know, the volume of inpatient patient visits decreased significantly during the onset of the pandemic, and that led to delays in cancer screening, routine care, routine vaccination for our patients, and it's also causing us to do a very quick transition to telehealth visits, including phone or video visits, and causing us to develop a protocol for disinfections and social distancing for our patients. And how does it affect our Hep B patients? So along with our regular patient, our Hep B patient also experience delay in blood testing and screening imaging because of shelter-in-place order. And also they run the risk of running out of medication because they cannot get the refills on time. And that can lead to hepatitis flare, which can be dangerous for them. And for our Hep B patient who are uninsured, this is more dangerous also because of the restriction in the pharmacy that they can go to. So there are only a few pharmacies that have the affordable antiviral treatments, and they have to go to this pharmacy to get medications. And also, the other issue is the blood test costs, because they have to go to certain lab center to get blood tests for a reduced cost, and for them to go anywhere else, it would be a lot more expensive. So when we transition to telehealth visits, we try to do this as quickly as possible during the pandemic to avoid the disruption of care for our elderlies and also for those who work or live out of states. This also helps reduce the risk of exposure for our patient and our providers. And another positive thing, which is pleasant, is that we are able to go in depth into review of medication with our patients, doing medication management and education, which is actually one of the great things. The difficulty about televisits is that we are unable to do physical evaluations. So what we try to do is that we get patients to do video visit as much as possible, so that way we can gauge to see how healthy they look, and also if they have any physical sign or symptom, they can show it to us. We ask them to do home vital sign monitoring, their blood pressure, their weight, and they can report that to us during visits. Some of the patients definitely have a lot of trouble with technology, particularly with video visits. So we're flexible with the type of visit that we do, either on video. We also ask the nursing staff to call the patient ahead of time to prepare them and to help them with registration for the visits. And we provide instructions in multiple languages for them also. In terms of medication, it is difficult for them to get their medication on time and frequently because of the fear of leaving their house. So we try to supply 3 months of medication if possible. And we try to change the pharmacy to somewhere closer to their home for convenience. And the same thing with blood tests and imaging. So we try to send the lab order or radiology order to centers near patient's home. The other thing we had to develop was the protocols for disinfection and social distancing. So initially, when at the peak of the pandemic, we did not have any on-site visits at all, and we transitioned fully to televisits for safety issues. And gradually, as the infection rate decreases, we start to open up for urgent care on-site visits for patients, and then for any routine visit for low-risk patients, because some patients do need to get their physical exam done for work or for school. And then we open up more for patients who need to be seen physically or who prefer to be seen physically. We clean surfaces frequently after patient visits. We provide PPE for clinical staff. We provide our front desk with barriers. We do phone screening and lobby screening to look for any sign of acute illness and fever. We try to schedule patients with a longer period of time for their visits, so that way they avoid crowding in the waiting room. And also we ask patients to come on time for their visits, so that way it's also avoid crowding. And we keep patients in separate room after registration until they check out, so that way they don't have to be in contact with other patients. For our hepatitis B program in particular, we have care management and free liver cancer screening for our uninsured patients. And we also have a program for care management of the pregnant woman to prevent vertical transmissions. So during the pandemic, our care managers continue to reach out to the patient through telephone to provide guidance, to act as a liaison between the providers, the pharmacies, and the patients, and to coordinate visits with providers, to help the patient work out ways to get the medication, either through getting family members to pick up the medicine for them, or asking pharmacy to mail the medication to the patients. So next I will be touching on the outreach effort during COVID-19. So, even during COVID-19, we try to do outreach and education for our patients. And we plan community events, and we also try to collaborate with other community organizations in order to encourage patients to continue to do Hep B screening and to get their tests done. So we have a program for free Hep B screening, vaccinations, and linkage to care. This program, we screened community members, but we also reach out to contacts of patients who have chronic Hep B, who basically have surface antigen positive. And we're also starting to reach out to patients who are core antibody positive and surface antigen negative. And we try to reach out to their contact also to get them to screen for hepatitis B. So during the COVID-19 pandemic, we stopped active enrollment during the peak of the pandemic, but the project coordinator continued to reach out through telephones to surface antigen positive patients for one-on-one educations about Hep B and the importance of having their contact tested. And we set up blood work at various lab centers near the patient, so that way it would be more convenient for them to do the test if they are interested in doing. And we did a few community screening events. We add the Hep B screening component to existing community events, such as the COVID-19 testing events, community health fair events, flu shots events. And at all these events, we make sure that we have patients pre-register so that we know how crowded it would be, so that we would be prepared to keep the social distance for the safety of the patient and our staff also. And at these events, we create one-page flyers with English and Chinese to promote the free hepatitis B screening at our clinic. And they can also share this flyer with their friends and family, or they can scan the QR code at the bottom of the flyer, so that way it would link to our website with more health resources for the patients. As the community organizations are slowly opening up and planning for all these outreach events, we also try to collaborate with them to promote resources and to provide Hep B screening in person. So we have collaborated with the Chinese American Planning Council, the Asian American Equality for Equality, the Flushing Business Improvement District to do the screening events locally. And we are planning and continuing to look for more community organizations to reach out to at this moment. So for future plans and things that we are in the planning process and working on right now, we are working on the Hep B educational webinar. This is something that we work with our partner, the African Services Committee, and we would present this webinar in Mandarin Chinese, tailoring to the Chinese immigrant community. And our partner, African Services Committee, will present the webinar to the African immigrant community in English and in French. So during this webinar, we would have live poll questions for participants to answer. And at the end of the webinar, we would have Q&A sessions for them. We do provide also the pre and post webinar surveys to evaluate the impact of these webinars on our participants. We plan to look into social media platforms such as Facebook, Twitter, to promote the Hep B services. And so far, we look into WeChat, which is widely used among the Chinese immigrant community. Other thing we also plan to do is live radio features with hepatitis B educations. We hope that this would reach a wider audience, particularly the older populations who do not use social media as much, and they would be passively tuning into to the session as they do their regular daily activity. So it's not too much disruption to their daily activities. So thank you very much. That concluded our presentations. If you have any questions or comments, you can contact me or you can contact Jane Wong, our program associate. And thank you everyone for this opportunity.
Thank you so much, Dr. Nguyen. Our next presenter is Dinate Yamani, who is a hepatitis B project coordinator for African Services Committee. She assists with performing the HBV screening process, information, registration, and tracking for study participants across 5 boroughs of New York City and supports other public health initiatives within the agency. She earned her Master of Public Health degree from Columbia University Milliman School of Public Health and Health Policy and Management and Human Rights, and her bachelor's degree in Public Health Studies in French from Johns Hopkins University. I'd also like to introduce our co-panelists who will be joining Dinate as well, who is Haley Matu-Conte, who is the Health Program Director at African Services Committee, where she oversees the operation of all public health initiatives within the agency, such as HIV, STI, maternal and infant health, and viral hepatitis. She earned her medical degree in Senegal, West Africa, where she worked for 10 years in the tuberculosis field in rural settings before joining the African Services Committee. Welcome.
Hello, my name is Dinate Yamani, and I'm the Hepatitis B Project Coordinator for African Services Committee. Today I'll be presenting along with my colleague Haley Matu-Conte, who's the Health Program Director here, about our Hepatitis B education and outreach during COVID-19. So to begin, I just want to give an outline of what I'll be discussing today. First, I'm going to start with a little information on our agency, and then I'll explain some background information on viral hepatitis and the objective of our Hepatitis B program. Afterwards, I'll discuss our Hepatitis B program prior to the COVID-19 pandemic and how we've transitioned during the pandemic. And then I'll discuss our plans for moving forward, acknowledge our partners, and open it up to the audience for any questions. So to give you a little bit of context about us, African Services Committee is a multi-service agency based here in Harlem, New York, and we're dedicated to assisting immigrants, refugees, and asylees from across the African diaspora. We provide health, housing, legal, educational, and social services to roughly 10,000 people each year. And today I'll be presenting on my team's work in the testing center regarding our viral hepatitis program before and during the COVID-19 pandemic. So to provide some context on hepatitis B and the African community, viral hepatitis can lead to liver cancer, which is a leading cause of cancer deaths worldwide. And African immigrants are particularly important to target because viral hepatitis is endemic to 8 to 20% of the African continent. So with that said, African immigrant communities are at great risk for viral hepatitis infection, and they're often unaware of their status. They also usually lack health insurance coverage to get tested, and suffer from language barriers and cultural differences with health practitioners in the U.S. So for these reasons, viral hepatitis education, screening, and outreach efforts are really critical to our work here at ASC because the clients we serve are vulnerable and lack the critical support and education necessary to combat viral hepatitis. The goal of our HBV program is to use viral hepatitis B and C education alongside early screenings, which we provide at our offsite testing events and at our office here in Harlem, as well as vaccination to increase liver cancer prevention and awareness among vulnerable African immigrant populations of New York City. So before the COVID-19 pandemic, ASC hosted viral hepatitis community awareness and screening events throughout New York City. And these events allowed participants to receive hepatitis B and C education and screenings for free. We provided educational resources and materials to participants, and we talked to them about the importance of getting tested and knowing their status. To promote our events to the community, we conducted outreach to African-born community members using radio ads on African stations. We posted about our events on social media, and we collaborated with community leaders and faith-based organizations serving the community. We developed promotional materials, which we also gave out for free at the screening events, and these were used to increase engagement and decrease stigma regarding testing. Upon arriving at each location for our testing events, it was also very beneficial that my team, which is primarily composed of African immigrants ourselves, reflected our target population because we were able to better connect with community members and provide culturally competent education on viral hepatitis in their native languages like French and Wolof. So this greatly increased the trust that we've established between the community and has empowered more people to participate in our screenings. The venues for our events were primarily at religious places of worship like mosques and churches, along with community centers, and of course our office here in Harlem. And depending on the results of our tests, our team followed up with participants to notify them and provide relevant support. So hepatitis B positive participants received free navigation to care and medical evaluations. Hepatitis B susceptible participants were provided a free 2-dose Heplisav vaccine here at African Services Committee, and participants who were immune were provided further viral hepatitis education and encouraged to forward their contacts to us if they knew of anyone else in their household or community who wanted to get tested. So between July 1st, 2019 and March 2020, when we shut down due to the pandemic, ASC had hosted roughly 16 community events in various boroughs across New York City, with 258 hepatitis B and C tests conducted. All of our positive clients were linked to care. Susceptible clients were offered the Heplisav 2-dose vaccine or opted to use their own provider for vaccination, and immune clients were notified of their results as well. We closed once the pandemic began in March, and we remained closed until July 2020. So this had a great, impact on our hepatitis B program. And during this time, our staff worked from home, and we followed up with clients regarding their health status during the pandemic and referred them to relevant facilities for telehealth visits, access to treatment, and also, referred them to our office for the food pantry as well to receive additional social support and services. We also encouraged clients to refer any contacts that they had to get tested once we reopened, which ended up being in July of this year. So we reopened on July 6, 2020, with COVID-19 precautions in place, like encouraging clients to make appointments for their services in advance so that we could predict the flow of people entering the office, requiring everyone to wear a mask, limiting the number of staff that we have present in each department, and of course having plenty of PPE in place. So we have plexiglass at our desks, ample hand sanitizer, masks, gloves, and again, we also check everyone's temperature every day when they come into the office. So we have several COVID-19 precautions in place. And we've also encouraged clients to come back to the office now that we have reopened, and I've promoted it on social media and on the agency's website. So staff have also followed up with clients to notify them that we've reopened, and again, have tried to encourage them to come in to continue their vaccination or for contacts to get tested. So since we've reopened, we've had a total of 75 people who have come in to get hepatitis B and C tests. And we've also collaborated with local community leaders to attempt hosting testing events again. Now, because the cases, of course, have started to increase, our testing events have been canceled, but we did have one event in September, which was really encouraging, and we were able to test a good number of people at that event and hope to have future testing events once the COVID-19 cases start to decrease and hopefully stabilize again. So moving forward, we will continue to provide viral hepatitis education and screening at our office. We're open Monday through Friday, 9 a.m. to 5 p.m., again, with all of the COVID-19 precautions that I mentioned before in place. We'll continue following up with our clients regarding their hepatitis B status to encourage vaccinations, linkage to care, and providing any contacts that they may have for additional testing. But we really are just waiting on the status of this pandemic. So once the cases have substantially decreased and stabilized, we will definitely attempt to, resume hosting our testing events at various locations across all 5 boroughs of New York City once it's safe enough to do so. To conclude, I'd just like to thank our partners at Charles B. Wang and the Coalition Against Hepatitis for People of African Origin, who have been supporting us in our efforts during this very unprecedented time. And I'd also like to thank the religious and community leaders that we work with continuously to host our testing events, and my team here at ASC. So with that said, I'd like to open it up to any questions or comments.
Great. Thank you all so much for your excellent presentations and continuing to serve communities all over the country during this challenging time. You have all clearly implemented innovative and unique strategies during this time, and we thank you for your hard work and your dedication to fighting viral hepatitis. I'd like to encourage our audience members at this time to submit questions and comments for our panelists. And I have a few questions that have come in that I'll direct first to Jane. If you could talk about your PPE distribution and specifically any strategies that you might suggest for other community partners. How did you do this safely? Did you receive any feedback from the community on this effort?
Thank you, Catherine. Yes, so in the beginning, around April time, we applied for funding for the mayor's office, Federal Department of Health. It's called the Hope Grant. It's and for was to build PPE to the communities that we saw, and to also to places where we potentially want to reach out to, and it was really well received. We distributed packages in a PPE package. We have masks, we have hand sanitizers, but we also promote hepatitis education pages as well as the information, and as well the places where they can get tested for COVID, and then also where they can get tested with us. Well, we had a online hybrid screening model, and it was really well received, and people really appreciate it. And then we also had made some contact in the future that actually recently that they really want, that they want us to go back and to provide some screenings. So it's a really good experience. Protect our staff is out, so we immediately had to do a COVID safety outreach and screening protocols, and so all our staff are trained how to protect ourselves with face masks as well as face shield if we have close contact, and hand sanitizers and gloves if we need to, and we always try to keep the distance. Thank you.
Great. Thanks, Jane. A couple of you mentioned providing screening activities during this time, and I know many partners have put that on hold, but I know Danette and Helimantu, you guys talked about screening in September. Can you share a little bit about different strategies that you use to maybe address some of the fear of the community potentially for and how you address COVID in this time?
Thank you, Catherine. We always aware about the CDC guideline for COVID-19, so that's what we update all the time on our social media and website, and we try to forward it also to our partners, our community leaders and community partners that we collaborate most of the time to conduct those hepatitis B testing events. So we try to resume our testing events, and those are our priority. So we share first that we share the all those precautions that needed before we conduct those testing events, and that's why we were able to conduct the first testing event that we have in Brooklyn in September, and we work with them prior to make sure that we respect all CDC guidelines for COVID-19. So we were able to have like a big open space and all the PPEs and respect social distancing. So participants were able to register before the event and then come at different times, so we won't have the crowd that we usually have when we conduct testing events. So that's why this is our first priority. So to inform them first about precaution, all those precautions needed before we conduct any testing event.
Thank you. Danette, anything to add to that?
I would just say that at the events as well, we always were prepared with plenty of PPE. So we had masks and gloves and hand sanitizer and tried to encourage people to be 6 feet apart so that we didn't have any spaces that were crowded when we only had one event. But we tried to make sure that we really were monitoring the number of people that were coming in.
Thanks. We have a question from the audience. Dr. Nguyen, your strategies to reach people during the pandemic were really thoughtful and creative. Do you foresee continuing and perhaps amplifying some, if not all, of the strategies that you've been implementing during the recent months?
Yes, so we do try to continue all those way of reaching out to the community as much as possible, especially to do collaboration with community organizations, because I feel in that way we can touch multiple things at one time. So like Hep B screening or giving other educational material, flu vaccines, or if possible COVID testing. So that way people, when they leave the house, they feel that they're getting multiple services at one time for the effort. And we try to make everything convenient for them as much as possible. We want to continue doing that as long as these organization does not need to close down because of the restriction in New York, as the flu season is coming around, the second wave is getting worse. It's kind of timing also, so we try to do as quick as possible, and then we might have to go back into doing a lot of webinar or online outreach, as the second wave hit us again. And then we restart again, hopefully in the spring.
Right. Thank you. This is for Yun. You mentioned keeping things simple and trying to meet the needs of people where they are. I think that's such an important point. Can you talk about strategies that you implemented to meet the needs of those that may not have, regular access to the internet or even just feel comfortable with using the internet, particularly for like the senior communities and others that might be more vulnerable?
Thank you, Catherine, for your question. Yeah, for that, because we conduct most of the education and either on Zoom as a webinar as a group or individual one-on-one. So if they don't have the internet access, we try to engage them through another way like phone call. Because for Zoom webinar, besides connecting to the internet, they could also call in. But we try to empower them to use more of the smart device so they could get the visual part of it. But for those who lack that, we provide that visual support through the material that they pick up when they come for the other need that they have. Like at our food distribution, they could come, they get the food, they could get hepatitis B testing, and we could provide extra information. And all of that, the difference between how we do it and the other places is that all of our activity are pre-registered. We get all the information, we get request form, food and everything. We take the information ahead of time. So when they come, they don't need to do anything or they don't need to get out of their car. What they need to do is that they just put their driver license on the windshield. We know that that's them, and then we drop off all they need in the trunk, and we contact them later for all the follow-up with the instruction of all the next steps.
That's great. Thank you. This question is for our team at the African Services Committee. This is coming from an Asian American group who has tried to do screening for the East African community in the San Diego area. They've at several approaches and they were met with negative answers. Do you have any suggestions for how to, I guess, create trust in the community and get a buy-in, I guess, and trust in that you can go out and provide that screening and those services that you're hoping to provide for the community?
I think that with trying to get buy-in and trust, it really helps if you have community members who are also involved. So if it's the East African community in particular in San Diego that they're attempting to target, then it would be helpful to have people who are East African who, speak Tigrinya or Amharic or Oromifa, like if they speak any of the East African languages and can, directly communicate with the community members. I think that's probably the most effective way to get trust. At least with us at ASC, most of our staff speak several other languages like Wolof or French, and a lot of the community members that we interact with are West African. So being able to communicate with people in their local languages has really helped with establishing that trust, I think, and making people comfortable to want to come to the events.
Anything to add?
So I would like to add it's important also to identify community leaders. We work a lot with community leaders, which are imam, the mosque, or pastors for church, any organization that they might have. So those are important people that help us all the time to get to the community. So we organize community leaders meeting. We always keep them informed about what we do and what we want to do, and they always like the liaison between us and the community. So the community members listen. Those are people that are trusted by the community, and they are the person that most of the time can transmit the message.
Okay, thank you. Well, I do believe that we are out of time, but I know we have some questions in the question box that have not been answered. I would encourage you to reach out to the panelists that are on the line now and maybe schedule one-on-one meetings to get more details on some of the content that they talked about. I want to take a moment as well to thank all of you so much for the great work you're doing in the community. It was really an inspiration to hear the different strategies that you guys are implementing on the ground, and certainly things that we will take as a coalition into our specific areas of location all across the United States. So thank you guys again. And with that, I'd like to conclude this panel session. Thank you all.
Thank you, Catherine.
Thank you.
Thank you.
Thank you.
Thank you so much, Catherine, and our wonderful panelists. Kudos to everyone for the amazing work you're doing, and especially during this time, and keeping all of our community members safe and safe from hepatitis B as well. So now we'd like to share a brief message from one of our sponsors. So please tune in to a Dynavax video. Hi, everyone. Welcome back. So this concludes our first part of our day on this platform. So what we're going to do now is take a 15-minute break, and then we will meet you in our breakout sessions this afternoon for the rest of the afternoon. So as you can see, we've run a little bit behind. So we are starting our breakout sessions a little bit behind. And if you are able to stick around about 15 to 20 minutes later in the day, that's wonderful. We are going to share links to the Zoom sessions in the chat box shortly, but you can also find those by navigating to the menu. So if you go to the left side navigation window panel, just click on Agenda. Find the breakout session that you're interested in attending. Session 7A is State and Local Hepatitis Elimination Planning. Session 7B is the path to universal adult hepatitis B vaccination. And there you will find the join session links. So just click on those, and then the Zoom details are also included in the session description box. So we'll now break for 15 minutes, and then we'll see you in our Zoom sessions. Thanks so much.